Good afternoon, everyone. Myself, Dr. Vinod Kaushik, on the behalf of IIP India Digital Team, just welcomes you all for this wonderful platform for sharing the knowledge. I just showed my gratitude to our Dr. Sanjeev K. Jha, IIP President, Dr. Ruchi Vashnai, IIP Women's Cell National Head, for providing us this wonderful platform. I just request everyone, please subscribe IIP India YouTube channel and like the other social IEP pages like on the Facebook and the Twitter. And I will just today the topic of discussion is recent trends in the hip and the knee arthroplasty. It's organized by IIP Women's Health South East Delhi District. And today we are having Dr. Dhananjay Gupta, Dr. Niti Khurana, Dr. Abha Sharma, Dr. Chandeep Singh, and Dr. Shikha with us for the panel discussion about this topic. And now I will just move on to our moderator. Please continue, ma'am.
Okay. Yeah. Good afternoon, everyone.
Hi.
Hello. Yeah. Am I audible to all?
Yeah.
Yeah. Good afternoon, and a very warm welcome to everyone. I am Dr. Deepti, physiotherapist, senior physiotherapist, Charak Palika NDMC Hospital. I am very happy and glad to see all of you joining us for this virtual webinar. I must say that this coronavirus pandemic has hit us and jolted us in a very, very unexpected and unprecedented way. It has totally disturbed our personal and professional life. I mean, we had never thought about it that how this thing, something of this magnitude can, rock us like this. But the silver lining, and I must say the good part is that we have devised new ways to lead our life in a, online thing. And the recent good example is this virtual webinar, which is organized by IIP Women Cell. And for that, I would like to thank our president, Dr. Sanjeev Jha, who's the president IIP. Then our Ruchi Vashne, Dr. Ruchi Vashne, she is the head Women Cell, IIP Women Cell head. Dr. Deepti Goyal, who is the head North Zonal head. Dr. Nidhi Kalra from Banarsi Das Chandiwala, she is our North head. And and then I think me and Shikha will be moderating this discussion about the recent advances in joint replacement, knee and hip joint replacement. Without starting, I mean, before we start this topic, I must tell you about something about the introduction, that what exactly we will be discussing about the total joint, this topic, that's the total joint arthroplasty. Now, what exactly is a total joint arthroplasty? It is a surgical procedure in which parts, that is the destroyed parts and the damaged parts of the joint, they are being removed and they are replaced by either a metal or a plastic or a ceramic device that is called an implant or a prosthesis. This prosthesis is basically designed to replicate the movement, that is to bring about the as normal movement that our natural joint used to do. In this hip arthroplasty, what is THR, that we call as total hip replacement or a total hip arthroplasty? This is done to remove the worn out or the damaged hip joint. An orthopedic surgeon replaces the old joint with the artificial joint, which we call as prosthesis, and then he replaces it with the prosthesis of the patient, and what is the best suitable for the patient's condition, that is it is done. The main indications for this are that either it is after a traumatic injury, or some severe arthritis or a hip fracture that cannot be managed through conservatively. And in TKR, that is total knee replacement, in that the surgeon takes out the damaged cartilage and the bone out of the knee and replaces them with a man-made joint. This operation is called a knee arthroplasty. Now, without wasting any further delay, I would like to call our esteemed panel of guests, that is Dr. Dhananjay Gupta, a very warm welcome, sir, who is Director Orthopedics and Joint Replacement in Fortis Rajan Dhal Hospital. Then we have Dr. Chandeep Singh with us, who is Associate Director Orthopedics, Max Institute of Musculoskeletal Sciences and Orthopedics, Delhi. Then we have with us our ma'am, Dr. Abha Sharma, who is a Chief Physiotherapist in Holy Family Hospital. Then Dr. Niti Khurana, who is a Senior Clinical Therapist in BCIIMS, Delhi. And me and Shikha, will be the moderator for the day, and Dr. Sandhya, who's our Southeast District Coordinator, she'll also be moderating with us. Thank you, sir. Now pass on the buck to you, please, sir. Please, passing on to you.
Thank you so much. I'm indeed thankful to Indian Association of Physiotherapists and the other people who have been actively involved in the functioning of this organization as well as in the academic program. So I have been asked to speak on this in total hip arthroplasty. It has been touted as the operation of the 20th century because of the excellent outcomes and the improvement in the quality of life which it has brought. And definitely, yes, something which has worked so well, but still the technical developments and the advancement, they keep on happening, and we are trying to make it performance-wise far better, and as well as to increase its longevity, because as per they say, as per the records, the total hip replacement or the knee joint replacement doesn't last for long. Right now, we are talking about survival of more than 15 years to 20 years only. If you look at this registry, you will find that if you see the various types of joint replacements which are being offered at the different age group. So starting from the younger one, let's say by the age, these are the indications for the trauma basically. So you have the blue line, these are the ones which are uncemented ones. Then you have reverse hybrid total hip replacement surgery. Then you have hybrid replacement surgery. And below at the much younger level, you have resurfacing joint replacement surgery. And above the age of 70 years, it is the cemented joint replacement surgery which is being offered. And if you look at the survival, we are looking at a particular implant surviving beyond a certain age, you'll find you have the best survival in the patients beyond 75 years of age, perhaps because their demand is not much, they are not putting much of stress on the implant, on the joint, that's why they're able to survive, and the least survival rate is in the patients which are younger than 50 years, much younger. And these are the ones who are very active, putting a lot of demand on the joints. And that's where all the focus of the development lies about. So when we talk about the developments, as we discussed earlier, the basic area where we need to work upon is the longevity. So that even if we do it at a younger age, we'll be able to give the patient their running hip joint for at least 25 to 30 years. Then you have very bad hip joints, like in dysplastic hips, dysplasias, congenital conditions, where your hip joint is so bad, even after the septic arthritis, equally, the anatomy becomes so distorted, it's very difficult to have a normal joint. In the patients who have spinopelvic deformities, because of the deformity of the spine as seen in the ankylosing spondylitis, as well as in the cases where the spine has been fused, and trauma in the active old patients. So this is the younger age group and the active age group which requires a prosthesis which once put in should be able to work for them for a long time with the maximum functionality. The various ways by which we have been able to somehow reach to that status is by introducing various aspects, various developments in the hip joint surgery. Let's try to take them one by one. So as we discuss, younger age, either because of trauma or because of avascular necrosis or because of DTH, that is dysplasia hip, you need to intervene much earlier to give them a good quality of life. So we are talking about the indications here, the various techniques we need to cover, whether we are doing cemented or uncemented. In the uncemented, we have to discuss about the porous surfaces, bearing surfaces, and the head size. They are very, very important. See, all these factors, they are very, very important in giving the longevity. And then about the perioperative management and the postoperative protocols, which can give us a fast track recovery from the patient so that we are able to put them back on their feet at the earliest. But let's not get carried away by all these so-called recent advances. We have to take them with a pinch of salt. I-12, there is no need to rush and buy it. Unless and until we know it's going to work for us, don't go for it. Because every advancement is something which is not going to be useful for you in terms of function or for the cost. So let's be wise. Let's take it slowly. So now coming to the modularity part. The earlier generation hip prosthesis used to be monoblock. Monoblock means you have head, neck, and shaft all combined together in one piece. It was very difficult to measure your bony cuts and do the soft tissue balancing. It used to be a very, very difficult task. Then we had your stem and neck along with its offset, which were inbuilt into it. Even they were also sort of monoblock. You could only adjust the height of the length of the neck by putting the headpiece over it. Then we are talking about absolute modular prosthesis, where you can change the version, you can change the offset, you can change the position by using this particular sleeve wherever you want to put it in the proximal part of the femur. So this is how modular we are becoming, making our job much, much easier. Otherwise, in such bad dysplastic hips would have been difficult or the next to impossible to put the hip joint replacement and give them a good quality of life. But as we discussed earlier, every advancement comes with its price also. And the modularity over here is associated with the risk where more modularity means more weak links in the joint, and they can break down or they can get dislocated, they can get disengaged and causing complication, that is revision surgery. The dual mobility cups, we have been hearing a lot about them. They've been in the market for past almost 8 to 10 years. And the basic indication you can say is especially in the patients where you have variable pelvic inclination, like ankylosing spondylitis, your spine is totally fused, or the post-fused spine. In such cases, your relationship between the acetabular cup and the head needs to be changed. It needs to be modular. So basically, this modularity here, you get dual mobility means the movement is happening at two places. So this is your first articulation. This is your acetabular cup. Then you have a liner into it, which can be metal or plastic. Nowadays, we are using the plastic liner here. Then you have a head, and then this is a larger head, which is called cup. And then you have another smaller head into it. So you are having movement at this particular interface and at this particular interface. So that's why you're getting mobility, dual mobility at two planes, making it more stable in the extreme of the movement. If this is the principle over here, as you can see, this is the conventional one. So whenever you go beyond the edge of this thing, your liner or the cup comes out. But in this particular situation, the dual mobility, chances are it may get disengaged, but again, it will come back into its position moment the position changes again. So this particular dual mobility has been indicated as we discussed in the specific cases of the pelvic and spine fusion, as well as in the older cases because of the muscle imbalance and poor muscle tone. In the young patients also, this is being considered and touted. They say that the stress risers as such, they are going to be minimum in this dual mobility cases. So if you put it in the younger age group, you will have a longer lifespan for this prosthesis. That is still debatable. We still don't have adequate results about it. We discussed about the resurfacing THR. Yes, it was a very good revolutionary concept about 15 to 20 years back. And the idea was, especially in the young patients who had a vascular necrosis of the head of the femur, only the head contour was distorted. So you simply resurface the head of the femur by preparing it and putting the implant over it. So by this way, you were able to preserve the bone stock for the future revision surgery. You were able to regain the native head size, which was supposed to be instrumental in getting almost normal biomechanics. So this is how you put the resurfacing head over it. And this is the conventional THR, where you have to cut off whole of the neck. This neck has to cut off, and you have to put the stem into the femoral canal. And of course, everything comes with a price. So this is your weak link here. You had so many cases where this particular bone used to get fractured, and the patients, they used to end up with an early recovery. Number one. Number two, this particular surgery requires so much of precision. It was not possible for an average orthopedic surgeon to give you adequate results. So that's why this particular surgery went out of vogue, and very few selective surgeons, they are still doing this type of surgery. Now, coming to the approaches, we all are going gaga over the minimal invasive anterior approach. Well, as we know, the hip joint can be approached from posteriorly, where you go between the glutei, between the gluteus medius and the gluteus maximus. Then you have lateral approach, where you go directly through the gluteus medius. Then you have anterior approach, where you try to develop a plane between the tensor fascia lata and sartorius, and deep between the rectus femoris and the gluteus medius. So it was supposed to be, it was again touted as a revolutionary outcome and advancement. The anterior approach, the hip, the scar used to lie anteriorly, and people, they had come out with the bikini incision also, very short cosmetic incision. But then this is how you approach it between the sartorius and the iliotibial band, and inside between the gluteus medius and the rectus femoris. And then it was realized that there's little evidence for improved kinematics or better long-term outcomes following the direct anterior approach. And there's a steep learning curve, and the complication rate is not less. The length of stay doesn't decrease, and the outcome remains the same. So again, we are back to the basic. The posterior approach remains the most preferred because the training is the most important factor, number one. And number two, the only problem with the posterior approach was increased dislocation rate, which has been taken care of with the improved implants and good capsular repair techniques. I think the sort of fight between the cemented and the uncemented stem will always continue. Now, what's the basic difference? If you look at this interface, you have a metal, and the cemented implant is always very shiny, very smooth surface, and then you have bone here. In between, the bone cement is used as a grout. It is not a glue. It is not adhesive. It simply provides a sort of a interlocking between the cancellous bone and the metal surface. So this space gets completely filled up. There is no place for the stem to subside, and it remains in that particular position. And when you talk about the uncemented stem, you have this metal, the stem, the surface has porous coating. So into this porous coating, the bone is supposed to grow from the surrounding, giving it long-lasting stability. So the issue is, till the bone grows into this surface, you have to get initial stability. Initial stability has always been an issue, and that's why in the initial stages, you have more failure. So it is supposed to be put press tight fit. You always put an oversized implant so that the initial stability you get because of that, and subsequently the bone is supposed to grow into this surface, giving it more stability later on. So the uncemented stems, this is cemented, absolutely smooth. Now, the uncemented, you have rough surfaces. You have two types of uncemented stems, one which promotes on-growth surfaces. So here, the surface is rough, textured, so that the bone can grow over it. Then you have ingrowth. So ingrowth means your surface has pores in it into which the bone can grow. So this is called ingrowth surface. The optimum pore size is 50 to 400 micrometer, and optimum percentage of void should be 30 to 50%, not more than this, otherwise the mechanical strength becomes an issue. Then they come in complete coating or in coating or they come in partial coating. A partial coating, you get only partial stability because only this much bone gets incorporated into it. But the point is that the stress remains, the stress is divided onto whole of the bone, providing better stability, better ingrow. In the complete one, the stress is bypassed and making this area less, this area particularly shows less integration into it. And if you look at the national registries of the various countries, you will find that over the period, the uncemented one seems to be showing a gradual increase in the incidence. More and more surgeons, they are using uncemented implants, though it has sort of plateaued off now since 2014, but still it's maintaining its lead over the uncemented or the hybrid ones. The uncemented ones. Now, when we talk about the survival rates, cemented versus uncemented, the debate goes on. It's just like fracture shaft femur or the periarticular fractures, the metaphyseal area. You have nailers, you have takers. Nailers will always come out with the ways and means to support their surgical decision, while the platers will always come out with the decisions how to support their particular procedure. If you look at the Swedish registry, you will find that the cemented stem, they show a higher failure rate over the period of time, because whatsoever good technique you use for the cementing, ultimately there is osteolysis leading to septic loosening. In the uncemented stem, as you can see, initially there is high failure rate, but around midway it stabilizes and it is much, much better as compared to the cemented ones. So from the stem, we come to the acetabular cups. These are the cemented cups. They can come with the rim liner also, and they can come with the pegs so as not to bottom out the acetabulum when they are pushed into the acetabulum. And the liner are supposed to keep the cup at the rim of the acetabulum so that the adequate cement film is maintained and it is kept under pressurization. And then you have uncemented so-called cups or the shells, which have porous coating over the whole circumference, and then they can be fixed either with the screws for the initial stability or with the pegs or the spikes. Most of them, they use metal shell with a polyethylene liner or the ceramic liner or even the metallic liner, and they are fastened securely inside it. And there are various locking mechanisms used for it. Now, again, if you look at the literature from the Swedish registry, they are also very clear that the uncemented cups, they over-survive your cemented THR in the long run. So coming to the bearing surfaces. Bearing surfaces, that means you have the head of the femur and the inner liner of the acetabulum. This can be hard on hard. Hard on hard means ceramic into ceramic, metal into metal. These are hard on hard. And then hard on soft is chromium cobalt head into or the ceramic head into the polyethylene liner. This is soft on hard. If you look at the literature, you will find that hard on hard is definitely superior, far better in terms of wear. Hard on soft has got higher wear rate, so that means longevity is less. But hard on hard has its own disadvantages. If you look at ceramic, on ceramic, you have high breakage rate because they are so stiff, they are very unforgiving. There's breakage, there's a streaking, and in the cases of metal on metal, you have ALVL. That means aseptic lymphocyte dominant vasculitis associated lesion, where this comes as a huge tumor, and this was the basic reason why metal on metal prosthesis went out of vogue. It is being sort of discarded, and it is not used anymore. Ceramic on ceramic, again, it has breakage and squeaking, so that's why the people, they are less inclined to use it. Ceramic on polyethylene, metal on polyethylene, and then ceramic again on polyethylene. So they seem to be working very well for us. Again, if you look at the registry of highly cross-linked polyethylene, their survival rate, this is my polyethylene, highly cross-linked, it has survived over the period of time, while your regular simple polyethylene is not able to survive. While your metal on metal, ceramic on ceramic, again, they could not do very well. So your highly cross-linked polyethylene has somehow solved the problem of survival when it comes down to the cup liners. Again, the survival rate of the highly crossing polyethylene seems to be far better as compared to the old poly one. If you look at the, again, at the registry, you will find that the cemented metal on polyethylene, I would say rather highly crossing polyethylene, seems to be doing far, far better. And more patients are using it because of its forgiving nature. And the cemented ceramic on poly is coming very far behind second. Cemented has failed to grow, rather it has become flat now. I would like to add another one thing here, that the people have started using vitamin E also in the highly crossing polyethylene, and somehow we still haven't been able to get adequate data, but they seem to be doing very well for the time being. And this is again the study about the failure rates. Higher the graph goes, more is the failure rate. So metal on metal, they are definitely out of vogue. You have still better survival with the ceramic on poly. Again, survival rate for the uncemented THR almost remains the same. If you follow, your ceramic on poly seems to be doing the best under the circumstances. So that was the cemented bearing surfaces. Now, if you look at the uncemented, again, ceramic, your metal on poly seems to be doing very well. Your ceramic on ceramic has seen a great rise, but now again it has come down. And what we are seeing now is uncemented ceramic on poly is the second best in terms of survival and the longevity. Now we come to the head size. We all talk about bigger the head, better it is. Why? Because the point is there's something called jump distance. The smaller head, jump distance is smaller, making it more prone to dislocate. The bigger size head needs to travel higher distance to make it eligible to come out. So this jump distance is more for the bigger head. That's why it's more stable. But unfortunately, when it comes to the wearing out of your liner, then bigger the head, more is the wear. So this is the balance which you need to maintain between the size of the head and, of course, your plastic liner. So as per this Australian registry, you will find that the highly cross-linked polyethylene with the size less than 32 and up to 32, they seem to be doing very well as compared to bigger size ones in terms of survival. Again, if you look at the survival of the uncemented, the head size, so your average size, the medium size heads, they seem to be doing very well. So as you can see, I think I have exhausted my time limit. So in the last, I would like to speak about the fast track surgeries. This is something which needs to be discussed in the team meetings between the anesthetist, the surgeon, and the post-surgery care providers like physiotherapists and the trained nurses. This is a collective team effort to reduce the surgical stress on the patient, on the surgeon, and you can facilitate the post-operative recovery of the patient so that the patient can be discharged on the same day of the surgery. Thank you so much for your patient hearing. I hope I have been able to do justice to the topic.
Can everybody hear me?
Yeah, Deepti, you're audible.
Thank you so much, sir. That was a indeed very great presentation of the facts and the depiction about the various types of implants used in hip arthroplasty. Sir, that is Dr. Dhananjay Gupta. He shared in-depth knowledge about the various mechanisms and surfaces that are used in the hip arthroplasty. He also threw light about the, all the indications that are uh, used for the different types of hip arthroplasty, sir. That is very good for highlighting, sir. Thank you so much, sir.
Thank
Now I
you.
would like to invite now I would like to invite our another esteemed guest, Dr. Chandeep Singh. Dr. Chandeep Singh, who is Associate Director Orthopedics, Max Institute of Musculoskeletal Sciences and Orthopedics, Delhi. Dr. Chandeep Singh, sir, I would like to welcome you, sir, to speak about total knee arthroplasty, sir. Thank you so much.
So I thank the Indian Association of Physiotherapists and also specifically the Southeast branch, the women's cell, for inviting me to give this talk. And I thank Dr. Dhananjay as well for this exhaustive lecture. I have gotten a hint already that I have to lessen my slides and finish this off quickly. So I will try to do justice in the shortest period of time. So if I skip my slides, that is under strict guidance is what I would like to say. So total knee replacement. We know that total knee replacement has been established over years, but in India, I think we have to give credit to Atal Bihari Vajpayee ji for making it popular. Though his surgery had a certain share of problems, but that ensured that even the common man knew about knee replacement. So we have been doing knee replacement for our varus knees. We get such bad knees, we do knee replacement, and we have long term. This is our 8-year follow up. We see them doing really well. Now this is a valgus knee where the knees are going outward, the knock knees. We do a knee replacement, we get them straight and we get them standing. We do see these follow ups. As Dr. Dhananjay had talked about, we get this subset of younger population who have such bad traumas and traumas which cannot be reconstructed. We have to do knee replacement for them also. And they are also doing well. This is another 6-year follow-up of the same patient. So if the knees are doing so well, why do we keep talking of doing better or improving results? Because as human as we are, we want to make things better. We want to make sure that every surgery we do, it does well. So change is the rule and change is life. We all know how change is from where we reach where. This is what we see. Though I wanted to cover so many topics, but I'll try and restrict my talk to a few of them, which I feel are very important. So we talk of implants. We all have heard about the high flex knees, the knees which make the knee bend more. However, repeated literature and repeated studies have found that it is the surgery and the pre-operative range of motion, the surgeon's skill, how to balance the knee, make sure that the knee is well balanced in the flexion and extension, and what was the pre-operative range of motion, which defines how much bending the knee will get. Then there is this talk of customized knees and the uncemented knees, or the tie-eye or the gold knee, which I will just mention here. We have gotten new implants. We have all heard of the attunes and the personas. Basically, these implants have learned from the mistakes made when the implants first came about in the 80s. We had implants which fit better on the distal femur, which fit better on the tibia, and ensure that you get a nicely balanced knees which are able to bend. You have improved the posterior curve of the femoral implant, so the knee bending is higher and you are able to reach a good this thing. We see this metal allergy, which is slightly more common in females in our country, probably because they wear jewelry and men wear less jewelry. So what do we do? We had this 62-year-old female who was allergic to metal, but her knees were really bad. What do? We had two options. One is the oxenium or the zirconium nitride, which is a ceramic coated implant, but the ceramic coat is on the femur only and not on the tibia. So that is why we could not think of using this implant for this lady. So what we used was this titanium nitride, the so-called gold knee. Now this is a hypoallergen. Basically, the metal is coated by a hypoallergen, and this tends to have a lesser chances of allergy. So these are the X-rays of the same lady that was talking about. This is the pre-op. We had to go one by one because we were doing an uncemented knee, and this was a newer implant. These are the intra-op photographs, and this is the final X-ray. This is an uncemented knee, titanium nitride, hypoallergen. Even in patients who have metal allergy, this can be done and it shows good long-term results. This is our 4-year follow-up with the same lady. There is this talk of robotic nowadays. Surprisingly, this is for me as a surprise. Well, robot is a word defined from a Czechoslovakian word meaning slave, meaning you are telling somebody else to do your work. The Da Vinci, the photograph that you would see, is a very commonly used robot specifically for surgery. But for orthopedic surgeries, robotics has started now. You have passive or the active robots. The active robots do not have a US FDA approval. The passive robots have an approval. Two companies have come up with it, and even in India, unicompartmental knees is where they started, but TKR also have got FDA approval, and we do have them in India. They help in ensuring that the bone cuts are absolutely accurate. You get the implant in the right position, and you are able to reproduce your results on every patient. They are reducing the human error involved in the doing of surgery, basically. So these are the three that we were talking about: the autonomous, the semi-apneic, and this is the robotic platforms that you have. Now, this is something that we all have been using. We have had our time, we had our difficulties, but computer assisted navigation is here to stay. Initially, there were big machines which are more expensive. Now you have handheld devices. They also offer you intra-op feedback so that you can ensure that your cuts are accurate. You can plan your surgeries, and you can intra-op measure the correction, your gaps, to get the balance exactly correctly. There have been debates whether CAS is actually beneficial or not. Dr. Dhananjay showed the registry data, but this is the data from Australian registry, which shows that in younger patients, computer navigated knees, they do have a better survival than the non-navigated ones. So probably over a period of time, the computer assisted surgeries will show better results. That's what we are saying. Now, this is the relatively new kid. I won't say a new kid on the block, but unicompartmentally. When the knee has three compartments, the medial, the lateral, and the patellofemoral, when only your one compartment is involved, you don't need to do a complete knee. You just replace that part of it, and it offers better kinematics than a total knee, gives you a more normal feeling, and technically you restrict your activities less post-op as compared to a total knee replacement. Now, this is something interesting that we started doing. We started doing uni knees in our octogenarians, our more than 80-year-old patients, because we wanted to minimize the surgical insult. And they specifically had only one-sided joint involvement. So this is an elderly Babaji that we did, who was very happy with his bilateral unicompartmental. He could sit cross-legged, do all his pujas. And we published this paper of 45 knees that we had followed up for 6 years. People have come out with a bicompartmental, doing a patellofemoral with a unicompartmental. When you have only one compartment which is spared, they say spare the one which you can spare, only replace which needs to be done. These are early designs which are still under consideration, but they are showing good results. Our closure techniques have changed from nylon to staples, and now something which is called dermabond, which is called a stitchless surgery, no stitch on the skin. Pain management is the key now for TKRs. I'm sure all of you in your practice have found that total hips, they pain less, and totally patients keep coming back to you. In fact, there are studies which say around 15-20% total knees have pain. So management of pain is very important for an optical post-op recovery. Analgesia has become multimodal. You do preemptive, local wound infiltration, nerve blocks, and analgesics. So basically, you are ensuring that you're covering your patient every time, so that once you go on your evening rounds, your patient is sitting up with the legs hanging, ensuring that she's able to walk. Local cocktail injections have become the flavor of the pain relief for knee. This is also what we have done. We have started using adductor canal blocks and local cocktail injections. You control the blood loss as well, ensure that there is less blood loss, and fast track surgery, as Dr. Dhananjay was saying. This is morning surgery. We try to get a patient to the washroom. To be honest, this is supposed to be an individualized approach. Not every patient will be able to do that. So basically, you aim for reduction in your post-operative length of stay, a shorter convalescence, and rapid recovery. And as Dr. Dhananjay said, I agree. It's a team effort. It is not a one person effort. And daycare TKR, I know this is the headlines that everybody would remember, but the key is you have to choose the right patient. Pre-op counseling is the key, and have the setup which is geared for it. In India, I still feel very strongly we have a long way to go for this. This is something which is very close to my heart. And as the number of joints increase, I'm sure all of us, including the physiotherapist, everybody is going to see it. Periprosthetic fractures, we are going to get more of them because we're going to have an elderly population who will have knees and who will break the bones around their joints, and they will need specialized care. Just to mention that this is something that is the next thing for all of us to watch for. I will skip this part. Thank you so much. Though you see only 3 faces there, but it's always the team which is standing behind. Thank you very much.
Thank you so much, Dr. Chandeep. That was indeed a great presentation, and I think answered a lot of our questions. Now I pass on to Dr. Sandhya, our district coordinator, Southeast District, Delhi, to ask few questions from both our esteemed guests, Dr. Chandeep Singh and Dr. Dhananjay Gupta, and also from Dr. Abha Sharma, Holy Family Hospital Chief Physiotherapist, and Dr. Niti, to answer few of our questions of viewers and of all the questions. Thank you so much, Doctor.
Yeah. Thank you, Deepti. Dr. Dhananjay, I want to one question is that what is a hybrid TKR?
Okay. TKR or THR.
Is that to me, Dr. Sandhya?
Hybrid.
Yeah.
So there are 2 ways you can put the implant, whether cemented or uncemented. When you say uncemented, that means both the components, that is hip, cup as well as femur, they were both put uncemented technically. But if one had to be used, if one was fixed with cement and the second was used without the cement, then it becomes hybrid. So in the conventional hybrid, the acetabular cup is uncemented while the femoral stem is cemented. Reverse hybrid, it becomes ulta. Your acetabular cup is cemented while the femoral stem becomes uncemented.
Dr. Chandeep, I need to ask one question. What is the weight bearing protocol for the total knee replacement? Ideally, what should be?
I'm sorry.
Can you hear me? Can you hear me?
I'm sorry, I couldn't hear the question. Can you please repeat it?
Yeah. What is the weight bearing protocol?
Yeah, now I can hear you, ma'am. Now I can hear you.
What is the weight bearing protocol? Ideal weight bearing protocol for a total knee replacement patients?
Ma'am, we make them stand full weight bearing as tolerated by pain. Our patients, they stand within 4 hours of surgery in the ICU. Basically, we have a separate HDU, which is for the joints. We make them stand within 4 hours. If they are able to, then walk a few steps. Otherwise, bedside commode training, full weight bearing, knee replacement, it's full weight bearing on day 0 of surgery.
The 0 day of surgery. Can you hear me? Dr. Dhananjay, one more question is that
Yes.
I want to know about the specific contraindication for the total hip replacement.
I think it's a very pertinent question because we all are talking about let's do it. I think if you talk about the absolute contraindication, then infection is one thing where you should not put your hands in because whatever you do is bound to get infected. So we have very rigid protocols, other fixed protocols. If the patient is having any infective focus close to that area where you're going to operate, or the patient is having septicemia, or bacteremia also, in such cases you do avoid. So as a pre-operative workup, we see to it, we ensure, we do a complete thorough physical examination, take the proper history, and do the blood test to rule out any of the infection, whether in the skin, in the lungs, even in the teeth, even in the urinary tract infection, whatever, it has to be ruled out. It's an absolute contraindication for us. And second, if I can put in the motivation of the patient, if it's something, which they don't want to undergo surgery, they're being pushed for it, and they're not willing to do post-operative physio rehab. That's Dr. Chandeep's cases of knee joint. In that case, one should not offer them the surgery.
Dr. Niti, you have some question you can ask Dr. Dhananjay?
Good afternoon, sir.
Niti.
Hanji sir. So my basic question is, after hip replacement, most of the times it's on weight bearing, sir. Biomechanically, we don't do an SLR because it puts too much of a stress on the implant. And most of these studies have suggested that walking is better, full weight bearing is better. But still, post THR, most of the time we do not do full weight bearing. Any reasons for it? Because I understand um, uh, most of the things, and like you've also taught me, the surgeon knows his surgery the best. So it's entirely the surgeon's point of view that you need to go as per his directions for the weight bearing training, sir. So why is that we don't do full weight bearing from day one, or say day 4 or a day 5, sir?
All right. So the concept here is not the full weight bearing. The concept is weight bearing as per pain tolerance.
Okay.
All right. Number one. Number two is ideally in the ideal situation circumstances, patient should be able to walk, take weight on that limb. All right. Unless and until I haven't been able to restore the normal biomechanics, or there have been instances where I have caused some iatrogenic fracture or some injury, some breakage somewhere, and I feel that few weeks of non-weight bearing may improve my chances of preventing any complication. Ideally, I should be prepared. If anything of the sort happens, I should have plate or the cables or the longer stem, all such situations inside the operation theater, so that I can take care of it then and there, rather than leaving it to the nature for subsequent. Because if you look at the biomechanics, the amount of force generated across the hip joint, because it's covered by such strong muscles, whenever they contract, they are able to cause damage if your biomechanics they haven't been restored, like your dislocation or aggravation of further fracture line or whatever. So even the simple activity should be able to recreate those complications which you have been avoiding. So weight bearing or keeping the patient on the bed, it doesn't matter really for that matter. If you feel that you've done a good job, patient should be up and about taking as much weight as he can.
Thank you, sir.
Just adding to Niti, maybe SLR in bed is what the patient might not be able to do, but otherwise in standing he can. And the other thing, weight bearing, full weight bearing is allowed by the doctor. It is, the patient may not be able to bear weight because of his other conditions, his pain, his tolerance, everything.
Abha has seen a lot more surgeons work, so she knows better. She was here with us at Orthonovo and subsequently at Holy Family. So definitely her spectrum of the surgeons and the post.
No, as they say that SLR in bed passes more forces across the hip and uncemented hip rather than weight bearing.
Yes.
So as Dr. Dhananjay said, the surgeon knows what he's done inside.
Yes, exactly. This is what Dhananjay sir told me. Surgeon knows his surgery best. Always ask the surgeon. Thank you.
It's also the condition of the bone. Sometimes the bone may also be so osteoporotic that there could have been in some incidents in the OT, which we as physios might not be able to understand. But that quality of the bone while putting the implant, the surgeon understands the best.
I agree. I agree.
Sir, I have a question to Dr. Dhananjay, sir.
Yes, Deepti, bolo.
Yeah, sir, now with the recent advances and with the new bone preserving implants, does this limb length still happens, this limb length deformity, which used to be a bit prominent complication post THR? Now also you come across this thing that the patients do complain of it post surgery, limb length discrepancy?
All right, see, it's not the actual limb length which matters. It is the ability of the soft tissue around the hip joint, such as your sciatic nerve or the femoral vessels, which are a matter of concern. So by convention, any limb length above 4 to 5 centimeters, it should not be addressed at the same sitting because you are likely to cause damage to the nerve. So that's the limiting factor for us. By hip joint replacement, you can only cause the lengthening of up to 4 to 5 centimeter. 4 centimeter is better. 5 centimeters is stretching a bit. If it requires more than that, then ideally you should be doing limb lengthening first by using the external fixator and then do the.
Sir, there is a question for Dr. Chandeep, sir, in the chat box from Deepthi. She wants to ask, do high flexion knees allow squatting or just permit better flexion in non-weight bearing positions?
So Deepthi, the answer to this is that theoretically they are supposed to cause improvement in squatting. However, as I said, it is the balance of the knee which allows you the movement, not necessarily the implant make. However, the use of a high flex knee in a better balanced knee will help you reach that squatting faster. Necessarily, all high flex knees will not lead to squatting. It is the skill of the surgeon and the pre-operative range of motion which are the key factors in ensuring getting a good range of motion post-operatively.
You can't leave everything on the implant. The local biomechanics, the muscles, the soft tissue, they are very, very important.
Sir, one thing I would like to ask Dr. Chandeep. Sir, apart from limb elevation, anything specific that you guide to a patient, regarding DVT prophylaxis, your deep vein thrombosis prophylaxis post TKR?
I am from a very, I work in a unit and our unit is of a very strong belief in chemoprophylaxis. That means we give medication post-op, that is one. Two, we are using TED stocking for 1 month. And limb elevation is not the key. Ankle pumps, TED stocking, and chemoprophylaxis in terms of a local aspirin. The aspirin tablet is given for post-op chemoprophylaxis.
Thank you so much, sir. Thanks a lot. I would also like to know from Dr. Abha and our Dr. Niti Khurana that what are the good braces that we use after post this TKR and THR?
As far as THR is concerned, I don't think so we need any brace. We have trained our patients pre-operatively and post-operatively. We are giving good physio. There is no need for any brace because hip is a deep joint. We need to tell the patient, advise the patient certain situations if the chances of dislocation are reduced. So the patient should not in the initial days, at least for the first 6 weeks, having the left leg adducted or seeing the midline of the body, internal rotation, as well as hip flexion more than 90 degrees. So bending the body forward to tie the shoe or pick up something from the floor or to sit on a low high chair, those all things should not be done as the hip replacement is concerned. As far as knee, again, if we worked upon the muscles well pre-operatively, post-operatively, most of the surgeons nowadays are not giving any braces post-TKR unless we're doing it in a very badly damaged knee pre-operatively or a rheumatoid knee where there has been a lot of soft tissue repair. So then maybe something to avoid a flexion deformity post-operatively which gets corrected and to prevent the varus and the valgus stress. So then nothing like a special brace, but a long leg brace in the initial
long knee brace, yes.
That would help.
Absolutely.
Thank you. I'm Dr. Niti Khurana, ma'am. I would like to ask that this is the general perception, patient is very apprehensive. So a very common question that the patients ask is when, a sporty person or a young individual, if he asks you that when will I be able to do other activities like golf, swimming or tennis, badminton after TKR or THR?
See, it really again depends, like sir also emphasized, it really depends on the kind of condition the patient is suffering from. Obviously, if it's a young patient, either it could be a big trauma or it could be some rheumatoid or any inflammation respiratory condition which he might be having. On that basis only we can start, and definitely in young adults we have a accelerated protocol to bring them back to their normal lives. So I think in their cases, I believe we can come down with a lot of accelerated and pre-op physiotherapy, pre-op training. We can come back to faster to all these sports again, as per the direction by the surgeon.
Dr. Deepti, by 3 weeks, the person may be allowed, he may be walking outdoors, he may even do swimming if the wound and everything, but ideally, anything after 4 weeks. But tennis or badminton, they should not be played after joint replacement. They are high impact games. Person can be maybe doing swimming, cycling.
Swimming post suture removal, swimming is allowed.
Swimming and swing is allowed. Tennis and badminton.
Tennis, patient can play after 3 months, depending on his muscle strength or her muscle strength. Non-contact sports, the patients do start playing. We have started using rotating platform in patients who want to play tennis. Now see, the only problem is competitive or non-competitive. The non-competitive tennis, in fact, after replacement, Andy Murray has gone back to play tennis. So that's okay. People, we are evolving. We are getting much better muscle power than what we used to get 10 years earlier. So our patients' demands, our patients' needs, this is a constantly evolving process right now. Patients want to get replacement done because they want to go back. They want to play their tennis 1 hour in the morning, or they want to play their golf 1 hour in the morning. You know, they want to have a good quality of life. So here the balance between the patient's expectations, what you can deliver, and what your physiotherapist can guide and ensure that the patient gets back to it. That is the key here, I think.
Thanks so much, sir. Thanks so much for enlightening. Sir, one question again I would like to ask Dr. Dhananjay. Sir, what are the lifting limits? I mean, how heavy a weight he can lift if he's a gymnast or if he is a sporty person or a weight lifter after doing a THR?
You're asking for too much, from a poor implant. I mean, why was the joint replacement surgery required? Because he was not able to do his activities of we never offered him the surgery because he could not jog, he could not run or something. Where survival decreases. So most of the impact coming onto the hip joint, more wear and tear, less will be the survival of the implant. He can do, as Chandeep said, he can do swimming, he can do cycling. See, in the specific subset, those who want normal functions like hiking, mountain climbing, for them, your resurfacing surgeries, they are far better because it's a normal biomechanics which have been restored. But still, we don't advise them to run and jog and do such activities because that's putting too much of stress. Range of movement is one thing, but the stress is something which should not be coming onto the joint.
Thanks so much, sir. Thank you.
Can I just add one more line to it, Dr. Deepti?
Mm-hmm.
Yeah, sure, sir.
So it's like somebody gives a brand new car to a 25-year-old. He will ensure that the tires are worn off in 5,000 kilometers. And somebody gives a brand new car to me, I will ensure the tires are sparkling clean even at 25,000 kilometers. So the more you use it, the more you abuse it.
So nice to put an end to it, sir. So nice to put an end, sir.
Thank you so much, everyone. I, Shikha Agarwal, Sub-Coordinator of Southeast Zone of IAP, would like to thank all the panelists for taking out their valuable time from their busy schedule. Thank you to each and every one of you for being here with us today. We are pleased to be able to welcome those of you that have been with us for years now, as well as those of you who are new to us, to this platform where IAP India helps creating free educational discussions, webinars, and seminars. Special thanks to Dr. Sanjeev Jha sir, Dr. Ruchi Vashne ma'am, Dr. Nidhi ma'am, Dr. Sandhya, Dr. Deepti, and myself for organizing such educational discussions for the upgradation of physiotherapy in the medical field. I believe that IAP shall continue conducting such educational discussions, webinars, and seminars for the profession at large. Thank you, everyone, for being here with us and sharing your information with us.
Thank you so much. It's been a pleasure.
Thank you.
Thank you so much.
Thank you.
Really wonderful webinar. I will just wind up this webinar now. And thanks to all the doctors, Dr. Dhananjay Gupta ji, Dr. Niti Khurana ma'am, Dr. Abha Sharma, Dr. Chandeep, and Dr. Shikha ma'am for conducting such a wonderful panel discussion about the topic. And I will show my gratitude towards again Dr. Sanjeev Keja and Dr. Vishnu ma'am. I just request everyone please subscribe our YouTube channel. Thanks for being